Our moderator provocateur tonight is Adel Mahmoud, who's a senior policy analyst and lecturer with the rank of professor, jointly appointed to the Wilson School and to Princeton's Department of Molecular Biology. He served as president of Merck Vaccines and was chairman of medicine and physician-in-chief at Case Western Reserve University and University Hospitals of Cleveland, and chief of geographic medicine there. His academic work has spanned the spectrum of bench research, field investigations in developing countries, and development of various policy recommendations related to that. We're also very fortunate to have with us tonight Osman Mansoor, who's a senior health advisor for UNICEF headquarters here in New York, responsible for new vaccine introductions. He's been providing technical advice on UNICEF's response to avian and pandemic influenza since 2005, and guided UNICEF's initial focus on behavior change as the primary line of defense in responding to disease threats. He's a medical graduate who's worked for several years as a general practitioner. He also worked for 4 years at the World Health Organization, where he was part of the SARS response team in Singapore and then the Philippines. We're also very fortunate to have with us tonight Laurie Garrett, a senior fellow for global health at the Council of Foreign Relations, also here in New York. She has the unique distinction of winning the 3 big Ps of journalism: the Peabody, the Polk, and of course the Pulitzer. Her expertise includes global health systems, chronic and infectious diseases, and bioterrorism, and I'm sure most, if not all of you, just read her very recent Newsweek cover story on H1N1. She's the best-selling author of The Coming Plague, Newly Emerging Diseases in a World Out of Balance, and Betrayal of Trust, The Collapse of Global Public Health. Also joining us is Peter Palese, who's a professor of microbiology and head of the Department of Microbiology at the Mount Sinai School of Medicine, again, here in New York. His research group at Mount Sinai looks at fundamental questions concerning the genetic makeup and the biology of viruses. And the group uses molecular biological techniques to understand how viruses replicate and how they interact with cells to cause disease in their hosts. Sounds very frightening. The group's emphasis is on the study of RNA viruses, which include influenza and the SARS viruses. He's a member of the National Academy of Sciences, has published widely in scientific journals, and among the accolades he's received, he's the recipient of the Austrian Medal of Honor for Science. Now with us tonight, also from the Wilson School, is Laura Kahn, an MD, who is a research scholar at the school's program on science and global security. Relevant to our discussion, especially here in the U.S., she led a 2-year study recently assessing the public health infrastructures of New Hampshire, New Jersey, New York, and Pennsylvania. Before coming to Princeton, she was managing physician for the New Jersey Department of Health and Senior Services and was a medical officer for the Food and Drug Administration. She's a monthly columnist now for the online Bulletin of the Atomic Scientists, which is a great read, and has authored the forthcoming book, Who's in Charge? Leadership During Epidemics. So, needless to say, we have a stellar group who will be able to shed some light on what the lessons of the H1N1 outbreak are thus far, and what can be done, if anything, to deal with the increasing threat of global pandemics. Thanks again for joining us, and I'll turn the floor over to Adel to moderate. Thank you.
Thank you very much, Steve. I just want to get quickly to our fantastic panel members here. But before we get there, the setting that we are dealing with is another chapter, another saga of the relationship between microbes and humans. And somehow or another, we, over the decades, over the centuries, in many ways, we never wanted to understand that relationship in an evolutionary, ecologically competent way. Fundamentally, we and the microbes are co-inhabitant of this group, and they have almost equal rights to be in this world that we occupy, and consequently, their ability to modify their existence and sometimes cause disease. It is not intentional, but sometimes it causes disease. But this relationship is really the subject that we're talking about today, yesterday, and we'll keep talking about it. And the fallacies of years past that antibiotics or antivirals, or we got rid of all infections and let's move on to other areas of pursuits, are really sobering, because suddenly there is HIV, suddenly there is SARS, suddenly there is the potential of a pandemic of flu, and it will continue. I don't know what tomorrow will bring us in that context. So with that sort of formulation, I'm going to invite Professor Peter Palese, who there is no equal. This is the guru of the virus that causes influenza. And we will try to make the presentations very crisp and short, so as we allow as much time as we can for questions and answers. Peter.
Thank you very much. Okay, so I just want to introduce the virus which causes influenza, and then give you a little bit of background what we sort of think about this virus, and try to answer the question whether this is a virus which can cause a bad pandemic. So the virus is a very small organism, and you can see here it is one electron microscopic particle or micrograph, and we can see in here 1, 2, 3, 4, 5, 6, 7, and 8 dark spots, which is basically the genetic information. These are mini chromosomes. So these are that's the information which is in the virus, which then actually one virus particle can kill a cell within 8 or 10 hours, and that's basically what happens when we get infected. And one of these virus particles can actually cause infection. So when someone coughs here and someone gets it into the respiratory tract, this one virus particle can do it. Now, what we also should look at is there's an outside here, and the outside is made up of a protein which is referred to as hemagglutinin, and that's the H in the H1N1, and then there's a second protein here which is the neuraminidase, and that is the N1 or N2, etc. So these are the important components of the virus itself. On the outside, the hemagglutinin standing with H1N1 for the neuraminidase. And that virus is causing the disease. And it's very, very small. So, for example, if we look at a cell, so if you blow up the virus, and then a cell would be probably like 3 Empire State Buildings. So that's a relative size of the virus versus one cell which gets infected. And within, as I said, 8 or 10 hours, one virus particle can basically destroy the Empire State Building. Now, in terms of human influenza viruses, we have several of these H1N1, H2, H3 in the last century, and also at the present time, we have viruses which are belonging to the H1 subtype. We have also viruses in 2009 which are belonging to the H3 subtype, and then we had before in the last century from 1957 on to 1968 H2, and then before that there were also H1 viruses. And as you can see here, in 1918 we also had an H1N1 virus which caused a lot of disease, a lot of morbidity, and a lot of mortality. So in order to understand influenza, we have to sort of make clear that this virus is very different from, for example, measles virus, where we had the same virus circulating for the last 50 years. That's not the case with influenza. We have these changes in the surface of the virus, where we have 1918, 1957, 1968, and then the return of this one. So whenever this hemagglutinin changes completely, we have no protection whatsoever, but also every 2 or 3 years the virus changes sufficiently so that we can get disease again. Now, we should also understand that there are actually 3 different influenza viruses which are circulating, not only the influenza A viruses, which belong to the H1 and H3, but also we have influenza B viruses. And then sort of it is interesting that we also have, before 1918, most likely H3 viruses. And that is sort of important because it might be that only these H1, H2, H3 viruses can really infect humans. There are a total of 16 different hemagglutinin subtypes out there in viruses which infect all kinds of animals, including whales, birds, pigs, etc. So we have 3 viruses circulating in 2009, and if we have vaccines, then they have to have these three components. So this was the vaccine which we got last season, October, November of 2008, and there was one H1, one H3, and an influenza B virus. And this is sort of just, shouldn't confuse it. The last number here is when the virus was isolated. This is usually the city or a state where the virus was isolated, and that's the isolate number. So this is really just sort of to give it a name. And we have two A viruses, an H1, H3, and a B. And for example, now for the next season, for the regular seasonal influenza, we have the same two H1 and H3, but we have a different B virus. So that's what we will have in 2009 and 2010. So what is now this swine virus? So this swine virus is an H1N1 virus, so belongs really into this group here. However, it is a little bit different. It is not a new subtype, but it is quite different from the other H1N1 viruses which have been circulating. And if we look at this here, we have here these 8 RNAs, these 8 chromosomes which I was mentioning before in the virus. And these 8 different chromosomes actually came from different influenza viruses. One was a human virus, one of these H3 and 2 types. Then 2 of these genes, 1 and 3, came actually from an avian, from a bird influenza virus, and the remaining 5 came from swine viruses. And the reason this swine virus has the name swine virus is because the hemagglutinin has this major glycoprotein on the virus has been derived from a swine influenza virus. So that's why we call it swine influenza virus. Now, what is important, however, is to understand 2 things about this virus. One is that it has a PB1. So there are these 8 different genes, and this PB1 gene is expressing also a virulence gene, which is referred to as PB1F2. And all of the pandemic strains which caused so much disease in the last century, 1918, 1957, 1968, they all have a PB1F2. The swine virus, however, does not have a PB1F2. It only has a PB1. So it's missing, it's lacking a virulence gene. So that's very important. And the second important aspect is that we all have been exposed to H1 viruses. So not only those of the few of us who were born before 1957, but also people who were born after 1977. And we all have been infected with H1N1 virus, and therefore we have some immunity. We refer to as herd immunity in the population. So there are 2 important things really in terms of the 2009 swine H1N1 influenza virus. It has glycoproteins which are belonging to the H1 and N1 surface subtype, and therefore it means that the human population has most likely a partial immunity against this virus. So we may get sick, and some unfortunate people are dying. However, most of them have some underlying disease which exacerbates infection with influenza. But I think overall we have some dampening in terms of the disease pattern of this H1N1 virus because it belongs to that group. And the other important thing is it is lacking, it does not express this virulence gene of PB1F2, which all of the other important, very virulent killer viruses in the last century had. So I think taken together, this is sort of probably just another, so a 4th regular influenza virus. So we have the 3, we have the H1, we have the H3 and the B among the regular seasonal influenza, and people die. We all know that about 30,000 people die a year of influenza infections. This one is probably sort of a 4th one, which belongs also to the H1 group, but it is not one which I think has sort of the pizzazz of a pandemic strain as we had it in the last century. Let me, perfect. Okay?
Thank you very much.
Good evening, everybody. I was thinking one of the lessons we have to learn is while we're all busy watching for H5N1 for several years, started to kind of maybe forget about it, even though H5N1 is still out there and still remains a potential threat. We don't know whether it can adapt. Something new happens. We get this new virus, and it turns out not to be so new. Okay. I'm really here to talk to you a little bit about the wider UN response, particularly some of the work that's done with UNICEF. And I think the concern about the H5N1 being a pandemic is really what triggered it in 2005 as this virus spread out from the world. And the UN system really got together and established the UN system influenza coordinator, David Nabarro, who helped to bring together a coherent response within the UN. And I think it's important, particularly for the poorest countries where they have the least access to the resources to respond to these threats. Each agency has a specific role and specific strengths in the UN family, and I think particularly when we're now responding with H1N1, it's very much under the technical leadership of the WHO. But the idea of having a coordinated, coherent response in the UN is something that has been built upon the earlier work that happened with avian and pandemic influenza. And I think the other lesson I think that we've learned from the current response is, despite all the preparations that have taken place, we're still really not prepared for responding to a major threat. I think we have a virus which is at the moment not seeming to be very much more than a seasonal influenza, although one of the questions is what is it going to do when this virus hits Africa, which I'm sure it will sooner or later, and particularly in high HIV prevalence countries, particularly in places which have got high mortality settings. And perhaps we won't even know, because these are the very places we have least knowledge about what's actually going on. We don't actually have real data about children, how many children are actually born, how many children are dying from different conditions. So I think it's very easy to get different perspectives about what's going on with the virus depending on what you see. And I think we will see over time what happens. But whether or not this virus does cause the major damage, I think we know that sooner or later we will be faced with new threats, whether they're viral or others. And I think that one of the things we've learnt is the strength of having this coordinated response and trying to deal with it. We will be getting new challenges, but we've also got better ways of addressing it. I think one of the remarkable things that happened in this pandemic is, so far, if it is a pandemic, I guess it is that it hasn't spread in the European countries after importation in most cases. There's some questions, obviously, in Britain and now in Japan and Australia. It does seem to be spreading, but in many countries there have been imports, by the way, nearly all from New York, and they actually haven't spread. And I think that's a reflection of the work that has been done. What happens when you do pay increased attention, and the fact that if you do have a coordinated response, as happened with SARS, it is possible to do things that we weren't able to do before. But it does require this coordination of efforts, and I think that's one of the key messages. I think the other aspect, and I think it's particularly going to be relevant if and when it comes to having vaccines, particularly to deal with it, is access to technologies. I think traditionally we have people get access to treatments who can afford them. The people who have the greatest need for them, the people who have the highest mortality, for example, with infectious disease, are the ones who are least likely to access the vaccines. And I think we are very likely to be in the same situation with H1N1, that the vaccine will be available, will be used in the Western nations where it has actually relatively small impacts, and will not be available in the countries where it will have the highest impacts. And I think this is really one of the key roles of the UN generally, and I think WHO is already starting the negotiations with the manufacturers. But what WHO is talking about is about reserving 10% of the supply for 80% of the world's population. I mean, that's progress, but there's still a long way to go. And I think there was a great editorial I saw a little while ago, I think in response to the killing of the pigs, which is about the need for science and solidarity in our response. And I think that's really important. I think both of those are really important. I think the science bit is important because we often forget about the science because of interests predominate. But the solidarity is important in terms of how we all behave as a global community is very important. And I think that reflects back to the point that was made in the introduction about the primary defense of behavior change as a control strategy. These are communicable diseases. how they pass from person to person depend on how people behave. And I think one of the challenges is that maybe some very small changes in behavior, like if we all just stayed a little bit further apart from each other, as well as hand washing and cough etiquette and staying home with sick, these changes in behavior can have major changes in how the diseases transmit if enough people participate in them. Everybody has to do it. Everybody has to. It's much better for everybody to make small changes and a few people to make large changes. I think it's the basic essence of public health, is trying to get everybody to engage in those critical changes that are going to make a difference. And I think in 2006 we worked with WHO on kind of determining what were likely to be the key behaviours to promote in a pandemic. And there was obvious things like hand hygiene, even though the evidence on transmission. Influenza virus is not so clear. There's good evidence about the importance of hand hygiene for other aspects. Illness behaviour in general, but particularly cough etiquette and staying home when sick, and perhaps that's clearly the most important. If people who are spreading the virus stay at home and don't give it to others, they're all safe, of course, apart from the other people who stay home, but that's another dimension of the challenge. But I think the most challenging aspect of it is the distance issue. Because the whole question is, how does virus transmit? And it's not a question of knowing how every single transmission occurs. It's how do the majority of transmissions occur? And the majority of transmissions do seem to require close distancing to each other. And I think one of the things I've been intrigued about in the response that we've seen so far is that distance does not tend to get mentioned as much as perhaps it could be. And the reason for that, I think, is very clear. Is because it's highly disruptive. How can you keep distance in the New York subway? And I think this is a challenge. How can we find solutions to make people keep distance in another way? And I think that is really fundamentally what we try and do with the communication strategies. We know the behaviours that we need to achieve, but it's not a question of telling how people to do those behaviours. You have to give them, saying this is the science, this is the basis behind it, and this is therefore why I would promote these behaviours. And you have to ask communities to say, how can you make those behaviours practical? How can you get communities to engage in these behaviours that are going to be protective, not just for yourself, but for your family and the wider community? I think I'm probably talking a little bit too long now, so I'm going to stop now. Thank you.
Thank you very much. So you have your slides on already.
Yes, I've got my notes. Good evening. I'm going to talk about One Health and an approach, new approach to influenza. Let's see, how do I... So what is One Health? Well, it's very simply a concept, and the concept is the interconnectedness between human and animal health and the environment. And what One Health seeks to do is to increase communication and collaboration between the various professions, namely physicians, veterinarians, public health professionals, and others. And it's a growing international movement of these professionals who recognize that they need to join forces in order to meet the challenges of the 21st century. Devastating diseases such as HIV/AIDS, SARS, Ebola, West Nile virus, rabies, they all come from animals, and so they are classified as zoonotic diseases. Oops. So why is One Health important? Well, as I mentioned, human and animal health are inextricably linked, and approximately 60% of all human pathogens are zoonotic, meaning that they come from animals. And since the mid-20th century, an increasing number of emerging infectious diseases have developed in humans, and 75% of them are zoonotic, meaning that they come from animals. There are many reasons for this, including socioeconomic, environmental, and ecological reasons why these diseases are emerging, including these processes include intensive agricultural practices, deforestation, ecosystem destruction, global travel, and trade. This trend is likely to worsen since the UN estimates that the world human population will go up to around 9 billion people by 2050. These practices are only going to get worse as we need to feed and house and meet the needs of this massive population. It's just a slide showing that these diseases have emerged globally. There isn't one particular region where they emerge. And I want to point out that influenza A, not B or C, but A, is a zoonotic disease. And the natural reservoir are wild waterfowl. such as ducks and geese and other birds. So you have to recognize that influenza A is part of life on this planet, just as tornadoes and hurricanes are. So we need to recognize that, and we need to deal with it. Now, this might seem like a simple concept to work together, but it's actually implementing it is harder than it would seem. So I just want to mention a little bit briefly about the history of veterinary medicine, because it originally was established to meet the needs of human health. So in the 18th century, there was an epidemic of rinderpest, which is a lethal viral disease of cattle. And Pope Clement the 11th asked his personal physician, Giovanni Maria Lancisi, to deal with this problem. And what Dr. Lancisi did was he recommended that all the ill or suspect animals be slaughtered. And this approach hasn't changed over the centuries. Our response to avian, avian influenza is to slaughter sick birds. So unfortunately, as time has gone on in the 20th century, the collaborative efforts between medicine and veterinary medicine have largely diverged, and human and animal diseases are treated as separate entities. And physicians and veterinarians rarely communicate or talk to each other in the clinical setting, in public health, or in research. And I would pose to you that medical students might not see the importance of zoonotic diseases or the impact on human and animal health. And veterinary medical schools have shifted their focus from livestock, large animal medicine, to meet the needs and demands of society and focus primarily on companion animal medicine. And while that's important, it really doesn't address issues like influenza. I'd also like to just mention to you that in the there's a divergence in the number of medical schools and veterinary medical schools. In the U.S., there are 125 accredited medical schools versus only 28 veterinary medical schools. Globally, the ratio is about the same. There's only about 39 accredited by AVMA, American Veterinary Medical Association standards, veterinary medical schools globally. And that really just doesn't meet our global needs. So in addition to this disparate number of medical schools versus veterinary medical schools, there's geographic and institutional barriers prohibiting physicians and veterinarians from working together. So what would a One Health approach be to a disease like to influenza in general? Well, you could argue that avian influenza has actually been a bit of a success because there has been surveillance of birds globally, and we have been able to keep the disease somewhat under control, although it is certainly spreading in birds, less so in humans. But we should increase cross-species surveillance and control, increase support for comparative medicine research, which is the study of disease processes across species. There's very little support for that, funding for that. There should be more joint efforts in the development and evaluation of new diagnostic methods, medicines and vaccines across all species, not just humans. There should be joint educational efforts between medical schools, veterinary medical schools, and schools of public health, and increasing efforts across in the clinical setting. I'd also just like to point out some of the benefits of comparative medicine research that I touched on. In 1893, Frederick L. Kilbourne, who was a veterinarian, and Theobald Smith, who was a physician, discovered that the cause of cattle fever was an infectious agent called Babesia bigemina that was transmitted by ticks. And their discovery set the stage for the discovery of yellow fever being transmitted by mosquitoes. So this was a monumental discovery. It was a physician and a veterinarian team, and they addressed an animal disease, and it ultimately impacted on human health. And more recently, in 1996, another physician-veterinarian team, Rolf Zinker-Nagel, who's a physician, and Peter Doherty, who is a veterinarian, won the Nobel Prize for their discovery of how the body distinguishes normal from virus-infected cells. So I think medicine and veterinary medicine are synergistic, they're complementary. We need to have them work together more, but yet we have a lot of barriers in place, institutional, financial, that prohibit this work. There are many organizations that support One Health, including the American Veterinary Medical Association, the AMA, the American Society for Microbiology, and these organizations have started working together to determine how One Health could be applied in academia, government settings, and industry. And we're trying to push to get an Institute of Medicine study to assess this issue. But it needs a lot more support by the public, policymakers, academicians, and industry leaders. And I'd just like to acknowledge my colleagues, Bruce Kaplan, Tom Moneth, and Jack Woodall. We have a website that's listed here, and it serves as a repository of all information concerning One Health. And thank you very much.
Thank you. Hard acts to follow. Quite hard. Let me just take us through a few key things that we've heard already. Abdel started off this discussion quite appropriately by reminding us that human beings live in an ecology that we share with microbes, that it is a fluid ecology not well understood and certainly not governed by any human forces. They reminded me of a wonderful colleague, no longer with us, Bernie Fields, who was at Harvard University, and who kept trying to make virologists listen to him and saying, look, you know, you can study the organism all you want, but you haven't figured out how the organism gets into the human body. And once in the body, how it gets into cells and produces the impact that it does. That means that we're in this fluid ecology full of microbes, but most of them are utterly harmless to us, perhaps even beneficial. What we haven't really understood is what are the things that dictate that moment when a microbe becomes a serious threat to our survival. What we do know is, and Peter reminded us of this, that the key is proteins and protein-protein interactions, key receptors on the surfaces of human cells and certain specific cell types. And does the microbe have the capacity to latch onto those receptors, gain entry into those crucial cell types? And does it have the capacity to produce highly virulent response? Peter happily told us that the H1N1 so-called swine flu lacks those two key issues. It does appear to have jumped the zoonotic bridge, meaning from one species it inhabits, pigs, to another, humans, to be able to infect us and infect certain cell types, but not the crucial cell types that appear to be responsible for highly contagious respiratory transmission and not the capacity to produce a virulent response. So can we relax? If I am Kathleen Sebelius, newly anointed as HHS Secretary, still trying to figure out where the Hubert Humphrey building is in Washington, D.C., and I have suddenly been faced with this giant dilemma, may I relax and assume that I have nothing to worry about? Osman says no, and he reminds us that one key reason is that we cannot produce enough vaccine and that there's no global equity in access to vaccine. It means that the rich world may have vaccine. I doubt it on time, by the way, but at least we'll have something. And we may have Tamiflu, a drug not mentioned here, oseltamivir, that is marginally helpful. But we won't have enough for everybody on the planet. In fact, for the majority of the planet, which undermines global solidarity and any sense of global cohesion of response. He offers as, therefore, the answer, let us look to social distancing. And one of the things that those of us that have been in epidemics around the world have noticed, certainly I in every epidemic I've been in, is that once the masks come out, while it's absolutely clear the mask doesn't actually protect you, unless you have an absolutely fitted N95, state-of-the-art, blah, 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 what they do accomplish is freaking out the person walking towards you. And I actually sat down with photographs, Osman, from subways in Mexico City and tried to get pictures of the same subway spots at roughly the same rush hour time before and after H1N1. And what I noticed very clearly is when lots of people are wearing masks, people are turning their heads away from one another. And though they're still crowded, they're doing this in the subway, and I think you all know what that's like. You've been in the New York subways when somebody started a really deep cough and everybody turned away. But social distancing is a principle that we know can make a difference, but not well understood, not clearly delineated, and certainly not laid out in a way that becomes a universal set of understandings in rich and poor countries alike, implementable whether you are in Tanzania or Manhattan. Laura Kahn reminds us that also missing as a crucial piece is an understanding that if we are talking about concern about zoonotic events, we need better surveillance that meshes wildlife surveillance, livestock surveillance, veterinary surveillance, and human surveillance. And what, of course, we here in New York City discovered in 1999 when a strange encephalitis virus emerged was that there were plenty of people on the phone saying, I have horses out on Long Island with encephalitis. I have birds at the Bronx Zoo with encephalitis. And our public health infrastructure said, we're busy, we're looking at humans, bye, click. And therefore we misdiagnosed it and misunderstood that an African bird virus had made its way to the United States, West Nile virus. And now, of course, we have it in just about every single state on a routine basis in the summer in the United States. So I think that Peter would have us calm down, and he would have us also calm down about H5N1, the avian flu virus that is in circulation. And I absolutely hope that he is right, that H5s are not amongst those capable of producing serious infections or certainly contagious infections in humans, so that the H5N1 bird flu virus need not be of serious concern for pandemic potential, and that the H1N1 so-called swine flu is lacking a key PB1 protein that would allow it to produce a virulent infection. And I absolutely hope he's correct on both counts. However, I have to think from a foreign policy point of view and a global response point of view. And that means that we cannot always assume that there's nothing to worry about. We have to always keep in mind the possibility of worst case or at least bad case scenarios. So when you come back to the notion of an ecology in which humans coexist with multiple microbes, but also other potential hosts, other species, pigs, chickens, horses, bats, wild animals, what have you. The one thing we can offer from a foreign policy point of view is better governance of that human piece of the pie. We learned in 2003 that countries in a globalized planet can no longer try to cover up outbreaks. China paid a price for spending 6 months denying that it had a new virus when SARS emerged. And it easily became an international problem because of one individual who went into Hong Kong, stayed in one hotel, and through means still not well understood, managed to pass his infection on to 12 other people staying on the 9th floor of the Hotel Metropole in downtown Hong Kong, who then got on planes afterwards and went to Toronto, Singapore, Hanoi, Beijing, etc. We have, as a result of that, and as a piece of global governance, the World Health Organization's World Health Assembly finally passed the International Health Regulations, which create a backbone of potential response for outbreaks and any contagious disease issue around the world. And we're really now watching the first ever attempt to implement those newly installed guidelines. One of the companion pieces of, if you want to call it legislation or rulemaking, put out by WHO was to create a pandemic staging system whereby we could alert the world appropriately to what was going on with microbes and get the entire world responding as one with a similar level of urgency, what have you. And what we're seeing is some real breakdowns, real challenges in both of these. First, on the pandemic staging. If you read the actual guidelines, we're now in allegedly pandemic 5, which is pandemic stage 5, which is actually pre-pandemic for H1N1. If you read the guidelines, we should be at pandemic 6, because what the guidelines call for is entirely based on geography and has nothing to do with the severity of the organism. So in theory, a new organism could come out of pigeons today and start spreading in people, producing nothing more than mild headaches. But if it starts first spreading among people in New York, and then spreads among people in Europe, and then spreads among people in Asia, we have to call it a pandemic 6. WHO now realizes that having guidelines based 100% on geography with no connection whatsoever to the risk to human health is not a good idea. And though we ought to be at pandemic 6, they have decided not to push us there. And that decision, they have overtly stated, is based on 3 things. 1, the emotional response likely to result from the world community by going to pandemic 6. I would argue the last consideration any group of scientists should have on their table is the emotional response that their hopefully empirically based statements would produce. The second is the concern that as a corollary of that, there would be an economic impact, meaning stock markets would go berserk. I think you would find the stock markets are preoccupied with other reasons to go berserk right now. And then finally, the notion that they have to get away from a geographically based system, that I would agree with. Now, on the side of the international health regulations and the notion that we have some kind of governance of response in epidemics, I think we've seen some real challenging indicators of changes that have to occur. First of all, Mexico's response was astounding. Gracias, Mexico. If indeed this had been a virulent organism, Mexico's response bought the world some time. They took very radical steps, and they are paying to the tune of hundreds of billions of dollars in an already beleaguered economy for the steps they took. There has been a dramatic reduction in remittances from the United States, from migrant workers, because they didn't leave Mexico or they can't get back to Mexico. The very great concern of taking virus one direction or another has actually slowed natural human movements back and forth across our border, not by government, but by individuals making choices. And Mexico's paid a price in the global marketplace, having everything from its airplane flights to products from Mexico boycotted for absolutely no rational reason based on science whatsoever. And among those that carried out irrational response towards Mexico was the government of China. In particular, China responded because what was once the Hotel Metropole, where SARS spread on the 9th floor to 12 people, is now called the Hotel Metro Park, where a person from Mexico was thought to be carrying the swine flu virus, and everybody from an entire plane load was placed under mandatory quarantine inside of said hotel. There was no scientific basis for that quarantine. That was a response by the Chinese state in memory of an event 6 years ago. But of course, the 2 most egregious in the global community have been Indonesia and Egypt. Now let me start with Indonesia. Indonesia has an interesting minister of health who has very unusual political views of the global political situation. And she decided in 2006 that the world was governed by a set of conspiracies that she needed to confront. The key conspiracy concerned the global control of the pharmaceutical industry, all in the hands of Christians and Jews in the Western world, who were involved in, alternatively based on which of her readings you decide reflects what she believes, are alternatively deliberately creating and releasing organisms into poor countries and then forcing the poor countries to buy the drugs from the rich countries to treat said organisms, or allowing organisms to spread that may naturally arise, maybe not made in a conspiracy in a biological weapons laboratory in the United States of America or NAMRU 2 located in Jakarta but run by the U.S. military. Maybe they naturally arose. However, our evil drug companies march in with the collusion of WHO, seize viral samples, come back, make vaccine, and then go to the poor country governments and say, now you have to buy vaccine from us. We're forcing you to do so. So she's declared the notion of viral sovereignty. Under this notion of viral sovereignty, nations possess and have all rights to whatever microbes they identify as emerging originally in their country. So therefore, she has refused to share some 62 different strains of the H5N1 bird flu that have appeared in human beings in her country with WHO or any other international body. As a result, we do not understand why the majority of all human cases in the last 3 years have been in Indonesia, nor why there may have been what looks like within families spread from human to human of that virus. Possibly. We don't know. She's also no longer permitting outsiders to do epidemiological investigations. This directly imperils the rest of the world, but her response is, until you give us guaranteed access to vaccine, we have a right to imperil the world with this. Unfortunately, for a long time it looked like her ideas were isolated and we wouldn't see a sort of contagion of viral sovereignty until the Muslim Brotherhood in Egypt decided that was a heck of a good idea and announced from the floors of the Cairo Parliament about 8 months ago that they too wanted to shut down a U.S. laboratory located in Cairo, Namru 3 it's called, and to stop sharing samples of H5N1 found in chickens and humans in Egypt. And Egypt now ranks number 2 in the number of human cases seen in the last 3 years in the world, so this is not trivial. Mind you, this is from chickens, from birds. But Egypt has responded to the threat of swine flu by slaughtering 300,000 pigs in Egypt, no chickens. And why are they killing the pigs? This is clearly using a disease for political ends. It has to do with repressing the minority Copt population, since, of course, the majority population, being Muslim, does not consume pork. So what would it look like if we had better governance in these situations? Well, first of all, there has to be some kind of an understanding of a two-way street. The rich world needs to guarantee to the poor world that, yes, we are striving to manufacture vaccine and drugs to scale for 6.5 billion people, not just for, let's say 500 million humans living in rich countries. And we do need to support the kinds of surveillance, not only of human cases, but animal and wildlife as well, in real networks located in rich and poor countries. And we need to deal with the crisis of scaled food production in ways that will not result in greater probability of zoonosis due to inappropriate, basically, manufacture of protein. Poor countries in return and emerging market societies must guarantee transparency. They have to say the quid pro quo is, we will tell you if we have outbreaks. We will alert the world. We will share our samples. They cannot be using diseases for political ends. And they must understand that as very fragile ecologies are destroyed in the expansion of societies, whether it's China eating up its northern territories, India destroying the Ganges, or the United States and whatever ecological devastation we may be doing, all of this affects the wildlife in ways that may make disease emergence a greater probability down the road. And we must begin to factor in, just as we do for climate change and CO2 emissions, the probability of wildlife zoonosis in our calculus of how to go about the process of building stronger economies in poor countries without at the same time imperiling humanity along the way. Thank you.
Thank you very much. So without any additional comments, I think we heard tremendous insights on 4 different aspects of the issue we are facing. And now I would like to open the floor for questions, and you either address it to any member of the panel or we'll just give it to whoever is willing to respond. There are microphones around, so please raise your hand and you will get a microphone over there next to you. Yeah. Please state your name for introduction.
My name is Tom Reed. I work for the New York City Department of Health. And I'm just curious whether we have been able to identify why this flu was more virulent in Mexico than anywhere else. Given what people have said on the panel, it didn't seem as though it should be that virulent. So what were the factors, and have they identified them?
Peter, you want to start?
Yeah. Okay. I think it's a very interesting question. I'm not sure that the premise is really correct, that the virus was more virulent in Mexico. And the reason is that, yes, we have the number of under 100 deaths, but we don't know the denominator. We don't know how many people were really sick in Mexico. So I think unless, and it is very difficult actually, even technically now, to prove that someone was infected 3 weeks ago by a swine influenza virus. So I would question the numbers at this point. We don't know how many deaths per total number of infected people we had in Mexico.
I just would also like to point out that most of the surveillance that was done, at least initially, was done in hospitals with the sickest patients. And so that spuriously also raised the death rate initially. All epidemics, crises, begin with some level of chaos and confusion. And the initial stages, the surveillance was done in the hospital, probably because it was easiest to do. There was one article in the Washington Post that said that about half of the entire Mexican population doesn't have insurance. They don't seek medical care. So if you don't see the doctor but you're sick, you have absolutely no idea, as Peter said, what the denominator is. So it gave it spuriously high death rates.
Thank you. Mansoor?
I would concur with those comments and also add the fact that we also have a richer versus the poorer nation and the impacts of that.
Laurie?
I would actually throw something back at you. I want to know why the heck the majority of at least identified cases in New York City have been school children. Why do we have spread in our schools, and there's really no other place outside of Mexico and the United States that's seeing some serious spread among school children? We have isolated school cases here and there around the country, but New York, it's what, 36 schools shut?
So as you can see, we have a tough panel, so we are addressing back the question to you.
Actually, there's been a lot of spread of school children in Japan.
Yeah, that's
and
new.
they're closing
that just
a lot
happened
of the schools
in the last 3 days.
Yeah.
But also Japan's overreacting. Anyway.
I don't know the answer. I can only speculate, too, that the same problem prevails here in the sense that, not everybody shows up in the denominator. And so, in a school environment, kids are in close proximity to each other. If they show evidence of being ill, it's more likely to be seen. Parents are maybe a little bit paranoid and make an error on the side of overly being cautious. And I think also in terms of the public health stance in New York City, it also walks that tightrope of, if anything, they err on the side of over caution. So they're more likely to close a school even if maybe there's not that much of a problem there.
But we clearly have had some schools in New York City where about 50% of the children have reported some of the symptomology associated with this virus. That is interesting. And it's also interesting, and these are the two things that, even though I think Peter's right that we're probably looking at a really benign virus, these are the two things that have me puzzled. Why is it spreading in that age group? And why is it spreading so late, way after our flu season, way after we've usually seen our very, very last notifiable flu case in New York City?
I don't want to respond by saying we really ought to take into consideration what happened in 1917. Because in 1917, actually, there was an increase in the death from flu, and nobody detected it or responded. And that was what happened in 1919, with 50 million people killed. So just one quick comment, because I really want the questions to come from the floor, not from the panel. Peter, okay. You're allowed to respond in less than 1 minute.
I would like to sort of put a little bit of doubt into the sort of notion that in 1918 there was a mild wave in the spring, which then really developed into this monster killing 50 million people. We have no evidence whether this mild wave in the spring of 1918 was really the 1918 virus. It could have been the old virus still. So we have no evidence for that. There are no sequences around. So I'm just not sure whether we can use that model from 1918 to be afraid for the 2009 swine
What
virus.
about 1957?
No, I'm going to stop this. I'm going to stop this. We will continue that later. Okay, I am going back to you. Yes, please. Microphone back there, please. Introduce yourself if you don't mind.
Okay. Martin Wang from China Xinhua News Agency. I have two questions. Now, first, I've heard that most of all the people died of the virus had pre-existing diseases. What are the diseases caused the deaths?
Okay, and what's the second question?
Yeah.
Okay, second one is there is a saying, actually, an estimate a few days ago, more than 100,000 people, Americans, are affected. Do you agree with this number? So, thank you.
Laurie, you made the comment that they all had some pre-existing conditions. I mean, how comfortable are you with the comment?
What we know, and this is coming from a combination of health departments like the New York City Health Department and our Centers for Disease Control, and then counterparts elsewhere in the world, is the majority of identified severe hospitalized cases and deaths have been in individuals with quote-unquote underlying conditions. For reasons of patient privacy, New York City has really not released the details to tell us what those underlying conditions were. In vague terms, our CDC has told us amongst them are diabetes, obesity, although I have to cast doubt on that because they said 20% of the individuals identified as having severe H1N1 were obese, and in the United States that would be low for our general obesity rate. So I'm not sure that's a fair assumption. What worries me is that we've not had anybody tell us one way or the other whether HIV has been an underlying condition in any case. Given what Osman noted, that this virus is now heading into the southern hemisphere, and in particular into sub-Saharan Africa, into communities where in the same age group that we're seeing as the key age group for H1N1 so far, school children, young adults, we have prevalences of HIV approaching 25%, and I've been in communities where it's more than 60% in key subsections of that reproductive age group. Then I'm very worried. One, what will H1N1 do when it finds such happy and comfortable hosts that are not able to mount immune responses to defeat the virus? And two, we do have studies on HIV-positive people in the United States with getting influenza infection if they are on antiretroviral therapy to treat their underlying HIV. And it's interesting, they seem to shed virus longer, up to 5 or 6 days longer, even though they may not themselves have a life-threatening illness. So then you worry about population impact.
Yeah. Questions from the floor? I'm going back to the audience. Please, microphone in the middle here. No, in front here.
Hi, my name's Corinne Whitaker. I actually come from the sort of sexual and reproductive health HIV community, so I have to say the discussion about distancing is one that draws a lot of concerns and questions. And I think just to add to some of the commentary that Laurie just offered, that there's sort of gender-based differences in HIV infection rates, there's gender-based differences in distancing, and there's even the ability, sort of exposure. I've also worked on trachoma issues where, the link between women and children and transmission is very real, so I think that's something we might want to consider. But I wanted to put out there, too, that I wondered if as part of this two-way street, it's a need to address some of the challenges that Mexico did incur in taking that risk. And so, putting in place something, obviously there's a limit to what you can do on back and forth remittances across the border that are unregulated. But if there's some element of that can also be part of international agreements, and even something taken up by an agency like WHO, which sort of takes it out of the political arena.
Well, I agree, and actually the danger is that the price that Mexico has paid for responding quickly, for responding very radically, and for shutting down its own businesses and so on, has been so negative that it sends a signal to the rest of the emerging markets of the world. Maybe it's not such a good idea to have a big response and be totally transparent and be a good global citizen, because what's in it for you? So I do think it's very important for the world to step up to the plate. And unfortunately, instead, we had Lou Dobbs and Rush Limbaugh and much of the right wing of our GOP using all this as an excuse to once again say we need a wall between us and Mexico.
So, Osman, I want you to respond.
To the wall? Or? I think we know the walls won't work.
Exactly.
There's so many different threads that I could take up here, and I think that the issue, I think, is back. I think the point that Laurie made is really important, that we have the incentives wrong. We still have polio circulating that should have been circulated, which should have been stopped 10 years ago, and the reasons are the incentives are wrong at the global level. We know that, and we're not doing anything about it. We've seen it now, I think, with the situation in Mexico. I think I very much agree with that, and I think it's really important that we do address those global incentives, just as we need to address the personal incentives to make the people to give people incentives to behave. I think one of the challenges with avian influenza is we were telling people to report disease, but when they report disease, it has very negative consequences on their community, and it doesn't make sense. You can't encourage people to do the right thing unless the policies are right.
But you got everybody to sign on the international health regulations.
I think the international health regulations help. They're clearly not enough, as we have seen.
Okay.
I think some of the responses, it's clearly a step forward, but I think there's more that is needed.
Okay. I agree. Yes, please. Back there.
Steve Barnes from the Woodrow Wilson School. I'm one of the organizers, but I can't resist. Laura, I mentioned in the opening your study of the 4 states in terms of public health preparedness, in terms of U.S. domestic preparedness for zoonotic or similar infectious disease threats. Curious to find out if you could expound a little bit on what some of the key findings were, and how these results may be updated now in terms of H1N1, if applicable. I also have a question for Osman. You talked a little bit about encouraging solidarity in terms of response, and also perhaps mitigating the crisis. From a policy and diplomatic standpoint, how do you encourage, promulgate, develop the political will to do so, and what have the specialized agencies across the U.S. system accomplished thus far with that? And also, perhaps, Laurie, if you could address that as well, I'd appreciate it. Thank you.
Okay, we'll start with Laura.
Yeah, so I studied New Hampshire, New Jersey, New York, and Pennsylvania. And the reason I included New Hampshire was a number of years ago, it was rated the healthiest state in the country, and I wanted to see what they were doing right. But I was also interested, so I didn't just study public health, I also studied agriculture. And I surveyed all the public health officers in the states. I surveyed a random sample of physicians and veterinarians, asking them questions about leadership, their understanding of the system of reporting diseases, a variety of other questions. And one of the things that led me to this conclusion that we need to have physicians and veterinarians work together is I asked them, do you ever talk to your colleagues who work on other species? And the physicians said no. And they really saw no relevance to their practice. Now, part of it, I have to say, is that it was a rather small sample response, and many of the physicians were subspecialists, and they didn't see these issues as relevant. And I think that's also part of the problem with medicine in general, is we've become so subspecialized in medicine that the people who would actually work with veterinarians are no longer practicing, the primary care physicians. I mean, it's a dying field, unfortunately. So that's a serious problem. The veterinarians are still, by and large, generalists, but they are also starting to lean towards subspecialization too, and I think that's a problem when we're dealing like issues such as communicable diseases, zoonotic diseases. The veterinarians, in terms of reporting zoonotic diseases, most of the veterinarians would report to the state agriculture department, although some state health departments also get involved. So there's a lot of confusion. States vary considerably in terms of their infrastructure, their reporting requirements. It's a real hodgepodge between human and animal health, and it's a mess. And most of the physicians and veterinarians really don't understand what's required. And some of them would just skip the entire state altogether and go straight to the CDC. So you have a very dysfunctional system. It's a serious problem. That having been said, one thing that I did find is that states where the funding of local public health comes from the state level as opposed to the local level, I think are in better shape. So for example, in New York, you have county-level health departments headed by physicians. Their funding is primarily from the state. Whereas in New Jersey, you've got primarily local-level health departments. Funding is local through taxes. We have about 500 local boards of health in New Jersey. That's more than all the entire states put together. It's an incredibly dysfunctional system. We have in our 22 counties, we have about 111 health departments. So that level of fragmentation, it's extremely hard to respond adequately to any kind of crisis. So, and Pennsylvania, again, is a completely different system. So, and that's just 4 states. So you can imagine what it is across the entire country. It just varies dramatically. So, you know, when you talk about responding, it's a very difficult scenario. The different professions don't talk to each other. We've got a dysfunctional medical healthcare system. It's, you know, we've got some serious issues that need to be addressed, and I quite frankly haven't seen it really on the front page of that, you know, of importance.
Thanks, Laura. Osman?
I think at the global level, I think there's something similar that's going on with the states. You have all this different mixed, these different systems, these different incentives that are in place. And I suspect the solution for the United States would be to have a unitary system, and I think the same thing for the world. You need some sort of unitary system, but there's huge political challenges to making that happen. Clearly, when you have crises like this is actually what helps move the agenda forward. Clearly, it was the SARS crisis that helps put the helped enable the international health regulations, and that is an advance. And I think it'll be interesting to see whether they can now be strengthened to address some of these failings that we have seen. But I think it's a really. I'll wait for the answer.
Can I just make one comment?
Yeah.
I just want to point out that microbes don't recognize political borders. So the more political borders you have, the harder it is to respond to it. And I would argue strongly that public health right now, public health in the U.S. is a state-level responsibility. I would argue it should be a federal responsibility, just like the FBI is the lead agency in terms of cross-state crime. The EPA is responsible for cross-state pollution. The CDC should be responsible for cross-state epidemics, but it's not. Its role is purely advisory to the states. The states are the ones that are in charge, and that's a serious problem.
If I could put it another way, a child, no matter where they're born, should have access to the same health, education, and basic services, right? But they don't.
Well, I will not comment, Osman, on this. Laurie?
Just quickly, we have an evolving debate going on right now across a whole range of issues, not just health issues, about global governance. And it's because since 9/11, there's been a real wake-up to governments all over the world that the key threats to their stability may have nothing to do with traditional nation-state interactions, bombs, bullets, or rival governments, but rather be due to transnational threats, climate change, pandemics, resource scarcities, energy crises, food crises, and of course the global financial crisis. And the problem with transnational threats is that they cannot be governed or controlled or even mitigated against through a single nation-state response or through traditional nation-state mechanisms. But the United Nations was created in 1948 as an institution based on the sovereignty and primacy of the nation-state. And with nation-states having equal vote whether they are Vanuatu or China. So we're not talking about proportional representation. And so what we see now are the first fitful steps of humanity in the 21st century, trying to come up with international accords that will work in the place of true governance, will somehow work with some incentives for appropriate cooperation. This is the Kyoto and now Copenhagen debates, Kyoto, Bali to Copenhagen, to come up with some CO2 capping mechanisms, some understanding of what, as a global community, we can do to lower our planetary carbon footprint. Similarly, the international health regulations were a first tiny baby step, but coming up with much more profound steps to ensure survival and health for humanity on an equitable basis are going to require mechanisms that I don't think we even fathom right now. But it's certainly on the table, and it's an aggressive debate. I don't think, however, to be perfectly frank, any time in the next decade or two, we're going to see any of the major nation-state governments back off and say, I yield authority to a global governance structure for issue X, Y, or Z.
Not easy. I'm going to ask one member of the audience a question. Raul, would you address where this virus came from, H1N1, the current one that is circulating? Is it something recent or something old that has been around?
From the sequences that have been deposited in public databases, they are basically like 200.
So take a microphone.
There are almost 300 sequences now. You can see that they're very similar. So because this virus is evolving very fast, you can just trace it back. And assuming that there is what is called molecular clock, so you know how many mutations do you have per unit time, you see that this virus is recent. So it happens basically, I mean, it's hard to estimate, but it's happening beginning of 2009, end of 2008. The common ancestor to all these ones. And this is one of the things. And the other question is, what are the closest relatives to the things that we have? And it seems that, so as Peter was saying, it seems that the different parts, they have different history. And the closest relatives, they're from North America swine and Asian swine. And the North American, there's basically what Peter was saying. So the North American, they are related to reassortments that happened in the last part of the 90s. They were a combination of human, avian, and swine viruses.
Okay. So, Peter, I mean, if the nature of the influenza virus is reassortment, that's how it lives, why would you be comfortable that it cannot reassort and acquire your virulence segment that you are, at least at this point, saying, as long as it's not there, I'm not as concerned?
Okay, Adel is sort of addressing a very important question. So I think we all agree that the present H1N1 swine virus is not really having a very high mortality rate. The question is, and I think it's a very good one, could this virus morph and mutate into something more virulent, either by mutations or acquiring one of these chromosomes we were talking about? And that we cannot exclude. Okay, so clearly, when I'm saying that this virus doesn't have it yet, I'm not arguing against pandemic measures. I'm not arguing that better safe than sorry. So clearly, there is some concern that such a virus or yet another one really comes around which has much more virulent properties. So I absolutely agree that this is a possibility. On the other hand, it doesn't happen that often. I would still argue that the 1918 virus was one out of a century, one out of a millennium, maybe out of 10 millennia. So it doesn't happen that often that something mixes in the right, it is like winning the lottery. It's not that highly likely.
Or losing the lottery.
I just one time.
I'm talking about the virus.
Yeah.
I want to ask you a
second,
follow-up.
Laurie, 1 second. Peter Palese is one of the few people in this world that chased the 1918 virus, and from segments in some people that died in the 1918 and were buried fortunately in such a circumstance where the DNA or pieces of the DNA were preserved. They pulled those pieces together and managed to come up with the complete sequence of the 1918. So, I mean, in some ways, this guy knows what that virus was from A to Z. So, Laurie, ask him the next question.
Yeah, I just have a follow-up question for you, Peter. Is there any inherent biological reason or rate-limiting point that would rule out the possibility that in an individual co-infected with the H5N1 and the H1N1 that you could get reassortment that would result in the virulence of H5N1 and the contagion of H1N1?
So, again, the H5N1 virus, if you are a chicken, is really very bad. Okay?
Well, it's not good if you're a
However, it does not have the property which a pandemic influenza virus needs, that is, be transmitted readily from one person to the other.
In humans,
So the question then is, could that virus, the H5N1, acquire that possibility or that characteristic? And again, the answer, we cannot exclude it. However, that these viruses have been around for some time. And H5N1, I have a 1959 H5N1 virus in my own laboratory from Glasgow. So these H5N1 viruses have been around, could have mixed, could have mutated, and it simply hasn't happened. Mm-hmm. So again, we cannot exclude it. But the virus should have had the chance of already doing it.
Okay, microphone back there, please. Our public health colleague.
Hi, back again. I'm just wondering if there is a commonality that can be identified among viruses that make the species jump to human transmission. If they all have something in common, if not, the exact same thing in common, then certain things in common that might identify a vulnerability, a way of treating these things that, regardless of their initial origins, kind of aim at that particular part that seems to make us susceptible to them. And I'm just wondering who on the panel, could respond to that.
We'll have to go to Peter.
I think that's sort of, I don't want to call it a $64,000 question, but clearly that is what we would like to know. And I think there are, unfortunately, probably different ways for the virus to do it. So it's not only just one way. I have to sort of not give you a clean answer on that because we really don't know.
What about targeting the M2 protein, which is common to all A-type influenza viruses?
You mean as a...
Either as a drug target or a vaccine target?
Again, so the question of a universal vaccine. Will we be able, even though the virus mutates around and does all of the things, will we be able to have either a drug which really will be able to counter the virus, or will we be able to make a vaccine? And again, I think, I want to believe it will be possible, but we are not there yet.
In the middle here, please.
Last question, please.
Okay.
Is there somebody else? Because I already asked.
No, go ahead. Go ahead.
Okay. I'm coming to this with a very political perspective, I guess. And the first thing I wanted to say is just make an appeal that any effort to sort of foster a One Health approach that comes out of the U.S. community is going to focus on medical doctors. But in the international community, the reality is that the other medical professions, whether it be auxiliary, whether it be midwives, whether it be pharmacists, who always get left out of the equation, definitely need to be there. So if in developing that model, there's a more holistic approach to it, I think that's important. And the AMA doesn't necessarily help with that, but I think, thinking about that from a political strategy. And I guess the other question is I'm at a very different point in my life, actually being the mother of a preschooler, and just to share a little bit that the experience of this, international health regulations and how that filters down into a country that is, fraught and now facing a major debate on healthcare reform once again, how that sort of gets perceived at the level of a community that I assumed would be very informed, attentive, and internationally sensitive, many of them working in international issues. And that is an absolute frenzy in a preschool about the fact that they think their children have this illness based on the symptomatology of it, and yet they can't get them tested without getting them admitted. Pediatricians will only treat it symptomatically. Pediatricians at this point aren't referring because they have to be, and so these parents end up calling multiple pediatricians, then they end up calling the hospitals. They try and figure a way around this, and it's what I'm sort of observing. It's creating amongst people who would be very sympathetic to more of a unified system that is really essential to this kind of an approach. Real resistance at a very, a very micro human level, which, is educational for me, coming from a perspective that very much supports that approach.
Thank you. So half a minute each of the panelists as a quick response. Half a minute.
To that?
Laura.
To her question.
To her question or to the general session?
We'll
start with Laura. We'll start with Laura because
you're absolutely right that it has, One Health has to be a general approach, and we do actually have a lot of nurses who support it, and allied health professionals who support it. We're working on getting the American Nurses Association to support it as well. We have many organizations who support it. Just for the lack of space, I couldn't list them all. But you're absolutely right. I'll defer.
Thank you. Osman.
And I think what you're raising is an issue that's often the problem in any response is you have the worried well swamping the ability of the system to deal with the real needs. And I think the same issues around equity. It's a challenge of communication, of understanding what are the drivers to those behaviours and what you can do to help support them.
So, Laurie, when are we going to get the healthcare system in this country? Somehow.
I don't want to talk
Half a minute.
I don't want to talk about the American healthcare system because it's not a system; it's chaos. No, I would just close with this thought that what you're now seeing emerging in the dialogue publicly is that WHO overreacted, Mexico overreacted. This is all a big brouhaha about nothing. And that's absolutely predictable. It happens with every single outbreak, that you begin with hysteria and you end up with a backlash attacking the very governing structures that were responsible for trying to respond. And if you get to the school level, any individual little cluster of community, you will have those that will scream, so-and-so is sick or died because you didn't do enough. And in the very same community, you overreacted, this is insane, you're hurting my business, what have you. You have to have decision and governance based on empirical evidence and put all of that off on the side.
Peter, are we going to have a vaccine?
Yeah, I just wanted to say I would like to sort of appeal that people really do take their regular influenza virus vaccine, and I can assure you that should the swine virus still circulate in October, November of this year, we will also have, the manufacturers will be able to get a monovalent vaccine against the swine virus. So we will have the regular seasonal, and it's just not taken enough. I mean, there's no reason why, if you want to get sick, then don't take it. But otherwise, I think one should really support vaccination in a much more dramatic way, and it is not a perfect vaccine, in a way that is not 100% effective, but it is very, very good. And I think we will have a vaccine against the swine virus should that virus be circulating in the fall, winter of this year.
Thank you very much. I just like the ending here. It's a public health ending. And finally, I just want to thank all of you and thank the panelists who have been really terrific. Thank you very much. Good night.